All right, why don't we begin in the interest of time? People are still they're still rolling in, but we'll get started. I'd like to go through first a few housekeeping items. Sorry, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island. We are grateful to have the opportunity to work on this land. The Temerty Center for AI Research and Education Medicine, or T-CAIREM, at the University of Toronto has been made possible by the generous donation from the Temerty family. T-CAIREM is an interdepartmental center that serves as a focal point for collaboration among healthcare providers, trainees, researchers, computer scientists, engineers, and industry, very, very multidisciplinary. And our goal is to transform health through AI. Just a quick note that this event is CPD accredited. To obtain your CPD credit, please use the QR code that will show on the screen at the end of today's presentation. And another note, for attendees who have Q&A questions during this presentation, please use the Q&A function in Zoom to submit your questions for today's speakers. We'll be addressing them during the discussion portion of this webinar. And by attending this event, you're consenting to become photographed or recorded for non-commercial use by T-CAIREM. So now that we have that out of the way, I'd like to introduce our incredible speakers for today. First is Dr. Shaf Keshavjee. We're honored and privileged to have Shaf join us today. Dr. Keshavjee is a world-renowned thoracic surgeon and director of the Toronto Lung Transplant Program. He is Chief of Innovation at University Health Network. He is Professor of Thoracic Surgery and Biomedical Engineering and Vice Chair of Innovation, Department of Surgery, Temerty Faculty of Medicine at the University of Toronto. I don't think he can take on any more jobs than he has currently. And we also have Dr. Andrew Sage. We're really thrilled to have Andrew here as well. Dr. Sage is an assistant scientist with the Toronto Lung Transplant Program at the Toronto General Hospital Research Institute and an assistant professor at the University of Toronto. He's a leader in integrating cutting-edge technologies such as machine learning, AI, and digital twins of human organs. In 2021, he was instrumental in the world's first drone-delivered human lung transplant in Toronto. So I'll now hand it over to our esteemed presenters. Thank you so much, Dr. Keshavjee and Dr. Sage.
Great. Thank you so much for having us present. And I'd really like, for people to ask questions because I know there's a lot of areas that we're learning as we go along as to how to use AI to make us better at what we do in medicine. I'm just going to see if it gets on for some slides. Okay. We have a number of disclosures, but specific to this presentation, I'm a shareholder and chief medical officer of Triferax Technologies that builds devices and fluids to perfuse lungs ex vivo, and we're going to talk about that. And both Andrew and I have a number of patents related to this work, and we work with University Health Network in terms of our academic integrity and relationship management. So today, what we'd like to do, are you seeing my slides okay? Yeah.
Yeah, yes, they look great.
Good, good. I just want to make sure is really get an understanding of the kind of data that we have learned to get out of lung transplant, lung organs and lung transplantation, and how to apply machine learning techniques to predict outcomes of both the lung and the patient afterwards, and then look at how to integrate these algorithms into clinical practice to enhance real-world transplant decision-making. Now, it's a real problem, and for those of you that don't know as much about transplantation and aren't immersed in this field, you might not know that every 9 minutes a person is added to the waiting list, and 17 people die each day waiting for an organ transplant. And this is even in the Canadian context. It's almost 5,000 Canadians a year are waiting for some sort of organ transplant. And Toronto General really has been a leader in lung transplantation. We are the leading lung transplant program and lung transplant innovation center in the world. We did the first successful single lung transplant in 1983 and the first successful double lung transplant in 1986 at Toronto General Hospital. And I would argue that every major innovation in lung transplantation since then has come from this center. And obviously I stand on the shoulders of the giants there, Joel Cooper, Alec Patterson, Griff Pearson, and Tom Todd, that really started the lung transplant program here and founded it on the research in lung transplantation and moving the field forward. Now, the problem is, while we can use many organs for transplant, really only 20% of the donor lungs that, when you've signed your consent, you're an organ donor and so on, only 20% of those lungs go on to be used for transplantation worldwide, and particularly in North America. So what we're trying to do is improve the number of lungs we use safely. And studies have shown that perhaps 40% or more of lungs that are turned down actually could have been used if we could have been more sure that they were safe to use. And so what we developed is a system to keep lungs outside the body, and a schematic of this is shown in the bottom right. Those are actual human lungs that were taken out of the organ donor about 9 hours prior to the time that this video was taken. And it basically, we can evaluate the lungs. We've developed a system to keep the lungs alive and maintained outside the body, not to stress them, but to interrogate them and find out if they're usable or not. And so this has become a huge part of lung transplantation in our center and worldwide. It's fully doubled the number of lung transplants that we can do per year. But we realized pretty quickly that there's a lot of data that comes out of donor lungs. And I just wanted to show you this picture. This is the device that we've developed that's now being used around Canada and around the world, where you basically put the lung in the cassette on the top right there. And what I showed you the video of first was our first generation component system. And this is in sort of all in one. You just click the case on and you run it. And it's got a full ICU ventilator in there and a full perfusion system and so on. It's a closed system, but it collects an incredible amount of data that feeds back to the clinician. I'm going to hand over to Andrew here.
Great. Okay, so as Shaf mentioned, the power of this sophisticated platform is to generate comprehensive multimodal data, and I think it's a really unique opportunity in our world to have data streams that truly cover all forms of omics, medical images, physiological function, as well as underlying biology and biochemistry. And so what we're showing here is just a snapshot of some of the data that we can collect from the ex vivo machine. So starting in the top left, medical images, we have x-rays, and I'll show some examples of that in the next few slides. We also have the ability to collect tissue biopsies. And so we do this multiple times throughout the ex vivo procedure. So we can measure transcriptomics. We can look at single cell changes in the organ with respect to time and injury. Because of the circulating perfusate, so the organs are perfused at 37 degrees, and we collect this acellular solution, we can look at the the biochemistry that's occurring in the solutions. We're looking at the electrolyte balance. We're looking at acid-base chemistry, subtle changes in pH. All of these things are monitored over time. And then importantly, as Shaf mentioned, with the ventilator, we have the ability to look at lung physiology. So we can see airway pressures, vascular pressures, the ability of the organ to perform gas exchange throughout the duration of ex vivo. And then continuing on this thread, we can measure metabolomics like glucose and lactate and others in the solution, as well as proteomics. So we do a lot of protein-based analyses on these organs. And I think one way to kind of think of this is it's very akin to the way that we have wearables now, where we've got, kind of continuous monitoring of our heart rate. But in the ex vivo system, it's really a comprehensive multimodal approach. And so to kind of go a mile deep into some of these data types, one of the most interesting parts in lung transplant is you have the clinical histories of two patients that become intertwined. And so from a machine learning perspective, one of the early data sources are the clinical charts from both the recipient and the donor themselves. And so we collect some of the high level data like age, sex, the recipient's disease. So shown on the right is just an example of that type of data. And it is just a snapshot. We have the whole history leading up to the transplant of the recipient that we can start to feed into these models. And then when the donor becomes available and we get access to the donor charts, a lot of the same information we can now access and put into our models. So, age and cause of death, whether or not they died from brain death or cardiac death. Their smoking history is a very important part for the work that we're doing in transplant. And so altogether, this type of data really does lend itself to sort of tabular machine learning models like XGBoost. And as mentioned earlier, the ability to collect photographs and images is really unique in the ex vivo setting. So starting on the far left, what you're seeing is a video of a deflation test. So towards the end of ex vivo, it's disconnected from the ventilator, and we can actually see the lungs deflate. And we record that for every case. And that's a way for us to now start to look from an imaging perspective how the lung is behaving. Not only that, in the middle panel, we take photographs so we can see changes at the photographic level of the lung before, during, and after EVLP. And then importantly, and we'll talk more throughout this discussion, the radiographs that we collect and the ability to have a pristine X-ray is something that's really, really unique. And as you can imagine, having this type of data across 1,000 clinical ex vivos is really well suited to the image-based machine learning models like CNNs. And on top of that, what I wanted to just quickly touch on is for the images, what's really powerful is that it aligns with all of our underlying sensor data. And so to that end, looking at some of our sensor data, again, we can now have timestamps and we measure some parameters are going to be hourly, like things that are coming from the blood gas machine, so measuring PO2s and gas exchange, but also glucose and lactate and the electrolytes are all things that we can measure hourly. And then very recently, we've really started to tap into the power of the ventilator because it's recording at a very high frequency the data of the lung on the ex vivo system. And so what you're seeing on the right here is a breath by breath profile of a given case. And so this is showing every single dynamic compliance measurement taken for, like I said, a single lung on the ex vivo circuit. And you can see how that dynamic compliance profile changes with respect to time. And we've got the markings of every clinical event that happened during the ex vivo, so whether or not bronchoscopy was performed, recruitment maneuvers, inspiratory pauses, all of those things are recorded. And so this really powerful time series data is where we leverage things like GRU and other sort of time series based models in our predictions. And so just to kind of move on to the next part, it's really the question is how do we take all of this data and now actually start to guide clinical decision making during transplantation?
And I think the really important part of this is as we rolled this technology out worldwide, we found that like if we put a lung on an ex vivo lung perfusion machine, we have a 70% chance of a successful transplant. And other very, very, very good lung transplant centers would have a success rate of 20 to 30%. And we figured, why is it that they're not having as much success, as good a success as we have? And I think part of the issue is what Andrew pointed out to you, that there's so much information there that humans can't really assimilate it as well. And this is where Bo Wang, who's our chief AI scientist at UHN, when he saw the data and the ability to the completeness of the data, the accuracy of the data, and the amount of data coming off the lung, this is a huge opportunity for AI to help humans do a better job at picking a lung for transplantation. So, we together with Andrew and Bo, we developed the InsightX model for ex vivo lung perfusion, which is really the first machine learning model to assess the lung and predict the outcome of the lung and the lung transplant afterwards. And as an example of some of the learnings we got from it in the development of the model, we saw in the training set with 500 cases, we had an area under the curve of about 79%, which held up when we did the test sets. And in terms of the point is that putting the lung on this machine, we can predict with accuracy that the patient's going to be extubated in less than 3 days off the ventilator and doing well, have a slightly or yellow, have a longer course in the ICU, but still a success in terms of saving a life. But in red, really, this is not a good lung. Don't transplant it, and it's a significant risk. And as we looked into the data in more detail, we saw that a good lung, the data points that the computer was looking at and using to make the decision was slightly different than a lung that had some risk factors. And you can see we've got both physiologic measures of the lung, biochemical measures, and biomarkers like IL-8 moves up the list in terms of a lung that's bad, and IL-6, and this corroborates with other biologic data that we have in the field, so that we're really being able to impart the knowledge of many years of experience and many EVLP cases to help with the decision making and improve the accuracy of decision making. We then designed a study, and Laura Donahoe, who's one of our newer lung transplant surgeons who focuses in education, really led this study where we looked at, we presented the ex vivo lung perfusion cases to the surgeons and fellows the way they would normally get it presented from our organ perfusion specialist. And then second, we blinded it and randomized it and mixed up the cases, presented it with the InsightX data added to it. And I think what this showed is that it increased the likelihood of transplanting good lungs, and it decreased the likelihood of transplanting lungs that were going to end up having a poor outcome. So really improve the decision making and selection of the surgeons in selecting a lung. But really, does this help in a real world setting? And this is again where we started to develop a way so that we could look at how do you display this information? How do you present it to the surgical team to say, yes, this is a good lung, or no, this isn't a good lung, and so on? And how do you do it? So Andrew designed a dashboard to present the InsightX dashboard so that we now can study that in real time.
Yeah, and this was a really important part of the work that we've done as we kind of move through the clinical development pathway, right? From a model that was validated retrospectively, and as Shaf mentioned, that study to show that there was clinical utility in a review or a retrospective setting. So to move forward, really, the dashboard was a really important piece, because how do you get this information to the surgical team in the right format? So we had a lot of consultations with the group because there's a lot of nuances to ex vivo. One of the things to consider, majority of the cases happen between 12 a.m. and 6 a.m. So they're typically overnight. And so, to that end, you don't necessarily want, I'll say, raw Python code or just a whole laundry list of SHAP values presented to the surgeon who may be on site, who may not be on site, maybe liaising with the perfusion team over email or video conferencing. So it was really important to get that right. And we wanted a way to quickly distill that expertise And as we've been chatting about, that was really where it came down to the model recommendation in the format of a, for lack of better sort of term, a traffic light system. Identifying those lungs that are most likely to be green lights, or the ones that do really well, extubated within 3 days. The yellow lights, where it's more of a caution, and you may or may not proceed depending on other sort of factors related to the recipient. And then ultimately, as we were discussing, those that are red lights and those that are unsuitable for transplant. But this was a way to quickly get that information across. And I think the other really important aspect of this comes from the building the trust in the decision that the model is giving. And how do you explain what the model was focused on? And so that comes back to Shaf values, and how you can display them. And so what we've done and built into the dashboard are really highlighting for each given scenario or each case, what is or what are the Shaf values or the findings that are driving the predictions. So it gives the surgeon the ability to see how the model made its decision as part of, like I said, that confidence and trust building exercise. And so one of the things as the hardware matures, we're working closely with the industry partner to have this dashboard be part of the console. So, as the ex vivo is running, this console or this dashboard is right there live with the case. And so, the second part of it, so it's one thing to get it right in terms of how to display the ML results. The second part is, how do we actually fit it into the clinical workflow? And so this was where we did, in the second step, a silence study. And really what we wanted to know is how do we integrate into the workflow seamlessly? And the other part that's really important for any ML model is just this kind of changing landscape of technology. So to kind of speak to those, we wanted to take a phased approach. We wanted to integrate and validate in an offline or a silent parallel study. So the first thing we had to do is figure out when exactly the reports would be given, when the dashboard would be released. And so one of the things we went back and we looked at historical patterns, and we basically observed that most of the decisions about transplantation for a lung on ex vivo occurred around the 3rd hour. So we wanted to make sure that the model results, the dashboard, everything was aligning with that time period. And so what that meant is we had to work backwards in terms of the data, obtaining the data, whether it be the AVGs or proteins. We wanted to make sure that all of those points were in and available to the model to run. And I'll just quickly touch on proteins because we're going to come back to that in a few minutes. But that was a really interesting one because current technology for protein detection, the fastest that off-the-shelf machines can do, it's about 70 minutes. So we had to really kind of start to do some analytics to figure out how to get protein data, run the assay, and get that information in time for the report. And then the third part is really, in this phase, who's running the actual test, right? Who's running the Python code? So we did have one of our team members sit in on every single one of these cases to actually run the code and liaise with the OPSs or the perfusion team to basically show that this can all be streamlined and set up for that. And then, as I mentioned, one of the most significant parts to all of this is the transition of hardware. And so as we've kind of shown, the EVLP hardware has transitioned from Gen 1, which was about 16 years of EVLP experience, to this Gen 2 all-in-one sophisticated device shown in the top right corner there. And the systems are the same, but you always need to do that sort of check. We need to make sure that there's been no data drifts and that. So another kind of value or benefit of doing the silent study was to actually do prospective validation on the latest generation of hardware. And so that's where we ultimately had about 45 cases in this clinical silent study. And you can see from the table there that the performance of Gen 1, where the model was trained and initially tested on, held up very robustly in the latest generation. So really gave us that confidence that the model was generalizable across eras and across devices. And so all of this is fantastic and really then just sets up to the stage 3. Where do we go next, or where are we currently? And it really comes down to the rollout phase and the go live phase. And ultimately, can we demonstrate that the model has clinical utility? We've seen in our previous studies, the ability to, or the ability of the model to guide or to help with decisions for ex vivo can have that impact. And so the question is does that happen in a real world setting? So all of that being said, is we're currently performing a randomized trial here at UHN. And so it's a 2-arm study where it's standard of care, so ex vivo happening the way that it's always happened, versus ex vivo plus the AI model. And really, it's the ability now for us to conclusively show this clinical utility of the model in a real world setting. It'll be the first RCT for AI models in transplant. And we're currently at about just over 50 clinical cases now, and we're seeing some really early or promising results in our early phases. So, we're right pretty much at the finish line in terms of where we want to go with this and go next. And kind of to that end, where do we go next? And so Shaf's going to talk about a lot of the innovation that's driving.
So one of the things that we did early on was we recognized that, as clinicians, we look at chest x-rays and therefore, we do a chest x-ray of the lung when we put it on a lung x-ray, if you will, and then we do it again at 3 hours. But we came to realize again that many surgeons doing lung transplants aren't that good at doing x-rays, and they're not always there. And these x-rays are very different. When you look at a normal chest x-ray, you've got the heart in the way, you've got ribs, you've got the chest wall, which can vary in thickness, and they're quite difficult to read and to see the lung behind there. Whereas an EVLP x-ray of the lung is actually quite clear. For those of you that are used to looking at x-rays, you can see the vasculature very clear. You can see curly B lines in there. You can see each lobe separately. And so what we did is Mike McInnes, who's one of our chest radiologists, actually individually looked at the score of each lung and looked at the change over time from 1 hour to 3 hour, and how the X-ray predicts the outcome of the lung over time. Bonnie Chow is the PhD student who worked with Andrew and I, and she looked at where are the abnormalities of the radiographic findings, and they actually tend to be more in the lower lobes of the lung over time. And again, we trained the system on over 100,000 X-rays from the NIH chest X-ray data bank, and then developed a CNN convolutional neural network based system to look at the prognostic accuracy of predicting lung transplant outcomes from the X-rays. And this was published here again, one more bit of data that really helps to improve the accuracy of decision making in selecting lungs that will work over time in ex vivo lung perfusion and safer lung transplantation. And there are a lot of things to figure out, like, when we looked at it, is the model looking at the right thing? Are they looking at the lungs? Are they looking at where the problems are? And we proved to ourselves that in fact the model was focusing on the areas of the lung that are more inclined to have problems, the lower lobes. And you can see in the declined lungs, the blue color is where the computer's focusing its attention in scoring these lungs. It definitely tends to focus on the areas where you're more likely to see lung injury. The other part of it is we realized is you can look on the X-ray on the left there, that the right lung, which is in the left side of the picture, is worse than the left lung. The left lung is clearer or darker, more air in it. And so again, we've been able to, when we put 2 lungs on, decide that maybe one lung is okay and one lung isn't, and we can evaluate it and use it for a single lung transplant to save a patient's life. And so again, starting to put all of these things together to improve and harness the richness of the data there. And again, all of you in AI know that some of this is the technology behind facial recognition and other things, but we can really harness that capability to improve what we do in healthcare and in selecting lungs for transplant. So X-ray images, video images, photographs, and everything. We have all of this data in addition to the physiologic and biochemical and biomarker data, putting it all together to make a more informed and accurate decision. And Andrew's going to talk to you a little bit about the stuff we're working on right now.
So one of the really powerful things of the system, as we talked about, is this ability to continue to collect additional data. And so, within reason, we can just add new sensors, we can collect more perfusate, we can bring a new data modality online. And so that's really been a driving force to the biomedical engineering aspect of it that we're really focused on. And so one of the things I wanted to touch on first is work that we're doing with Waterloo. Because as I mentioned earlier, with the proteins is a fantastic example. Current ELISA technology, even the fastest off the shelf, is about 70 minutes. And that's still far too slow for our applications. But there's a lot of really promising work as it relates to real-time sensing. And so this collaboration that we're doing is really leveraging quantum dots and aptamers to really build an inline microfluidic device to convert those data modalities that were offline hourly measurements into minute by minute or real-time measurements. And so across the top, what we're really looking at is just this strategy to convert, in this set of examples, glucose, lactate, and protein data into a sensible readout that we can then attach to the ex vivo system. And so in the bottom here, we're showing the schematic where we can actually just have a port where we can draw just a small volume of that perfusate solution into this new device, which is, like I said, it's a microfluidic optical reader that's giving us now glucose and lactate minute by minute measurements. And that's a really important part to making more data available, new data available. And really from an ML perspective, it gives us more and more lines in the multimodal data stream of timestamps and data that we can start to then line up for additional analytics. Because ultimately our goal is to have all of these data modalities providing high resolution data that we can do really interesting and important time series measurements. It also gives us the ability to do more hands-free so that you're not asking someone in the room to collect a sample, walk down the hall, do an ABG measurement. This is all just happening inline in the system. And so to kind of to show that in terms of what can we do with our high resolution data, what we're looking at here now is when we take breath by breath data and we apply an MLP based model, we can actually forecast at the individual breath level with a high degree of accuracy. So this is using a recursive approach. And so what you're seeing is the observed data, which was in blue, the forecasted horizon, which is in yellow, and then the upcoming real data, which is in green. And you can see that we're really getting this high degree of accuracy. And remember, this is at an individual breath that we can predict within a couple of mils of centimeter water for dynamic compliance, the measurements that we're about to observe on this platform. And so what it really provides is an opportunity now for this ultra precise and powerful data that we can use to make better assessments about the organ. So we're always trying to continually now push the insight model and make even more advanced predictions. And having this type of data structure and these types of models are really a powerful way of the future.
So I'll just wrap up a little bit. As you can see, we had been transplanting lungs the same way that we'd done all of this since the beginning. Right now we've moved lung transplantation from a 50% mortality in the 80s to a 1.5% operative mortality now currently in our program, and we've gone to doing over 200 lung transplants a year, which is the biggest in the world. But EVLP has allowed us to use lungs we never used before, but really we can improve on it, and we've realized that we have a lot of data collected in a very accurate way, in a very complete way, with 100% follow-up on our patients. So we can really harness the power of machine learning and AI algorithms to improve our selection and the accuracy of our selection of lungs going forward. So the other part that's very interesting is we've got a whole team studying this in the lab, but we've looked at how do we translate this into practice? How do we actually put AI into the decision making in a very complex area like lung transplantation? And as you can see, I think you'll all appreciate it's a pretty exciting area for and ripe for improvement with artificial intelligence to enhance the way we make our decisions. So we'd both like to thank you again for the opportunity to present. We have a lot of people, and particularly Bo, who has helped us a lot, and you know, the whole team in terms of the lab fellows, the masters and PhD students, and our postdocs, as well as the clinical team and the organ perfusion specialists that have helped us to continue to push the boundaries forward in terms of developing AI for lung transplantation. So we're happy to take any questions from you now. I'll stop sharing so we can see you, and we're happy to have a discussion.
Great, thank you. Terrific presentation. Really exciting stuff that's happening there. And obviously incredible implications for patient care and delivery of care, and hopefully significant impacts on patient outcomes. We do have a question in the Q&A section. The question says, as you said, the model predicts the likelihood of successful transplantation of each lung. Is there a functionality in the system to learn from the outcome of these transplants? And I'm assuming they're referring to static models versus dynamic models, or machine learned, which are static, versus learning, which kind of adapt as you get more and more cases.
Yeah, so right now the current setup is a static, where we basically are training it more in a cohort style. But one of the things kind of to the question here is really the ability to see these temporal changes. And it's really interesting to track, you know, model predictions and clinical outcomes, you know, by era. And we've seen these sort of differences because the clinical team has gotten a lot more experience as each case happens with, you know, what is going to be a suitable lung associated with a good outcome. So for now, our strategy has been static and kind of continuing to look at these sort of temporal changes in that way. But one of the things we are for sure interested in and looking at is on a case-by-case sort of more dynamic learning, where we can then take the feedback from a case that happened on the weekend and then feed that into the model so that it becomes more of a live model. And I mean, there's a lot of implications there as it relates to rollout and validation, and even with Health Canada and that. So there's a couple of things we need to consider there. But ultimately, from a machine learning perspective, I think that's also, it's going to be a really important parallel strategy that we're able to do.
That's fantastic. And on a related note, what about feedback loop issues if you get into these dynamic kind of adjusting models? You know, the issue is that as you're actually putting in predictions, you're changing physician decision making, and then it learns from those changed decisions, which kind of quote unquote tainted data, I guess, at that point, because it's not being affected by the interventions. So how do you then keep learning in an unbiased way?
Yeah, you know, the important thing about how you can actually harness and use that bias to your advantage. I mean, the reality is 19% of lungs are transplanted, right? And it's a very high risk procedure. People don't not use a lung because they're lazy or stupid. They just don't want to kill somebody, right? So the issue is those are the things to look at. Transplant more than 19% and decrease the mortality and transplant more people. So, you know, whether it's a built-in bias, which we do get accused of. Everybody's, well, yeah, that's just Toronto people. Well, yeah, well, it's Toronto, but we are the best in the world and we do transplant the most. So, I mean, you know, it's a sort of flagrant thing to say, but the point of it is if it works and it's made us better, we're using something different than the biased AI to measure our outcomes, right? Our outcomes are, have we got more people alive? Are we using more of this scarce resource? So I think, again, that's an example where if you look at AI academically and the risks of it and the biases, you can also look at it and say, wait a minute, the whole point is different. Like if AI is biased or making decisions based on your last decision, the end of the proof of the pudding is the patient.
Yeah, absolutely. Absolutely. No, that's helpful. I guess there is another question in the window, but I'm going to take the prerogative of the host, I guess, and ask a question. When we actually build these models, we often kind of have some of these expectations of these performance metrics. What's the precision? What's the recall? But it's often compared to something, actually, it's often not compared to anything at all. Often it's just like, hey, this is how the model performs. When really what you're doing is you're comparing to clinician judgment, right? At the end of the day, the basic standard is the clinician says this would be a successful lung transplant. Do we have a sense of how good clinicians are? Because then that would set the threshold around what the algorithm has to beat.
Yeah. So that's one of the challenges for us. But for example, there are 79 lung transplant programs in the United States, and the clinicians turn the lungs down, and then they're offered to Canada, and we take 60 lungs a year, 60. Okay, so that's where a clinician has made a decision that it's not a good lung, and we as clinicians decide that it's okay to do it, and with equally good outcomes. So we're trying to improve that decision making of saying, are the clinicians right? And it's a difficult one because we think, like in analyses of lungs that weren't used, they've said, well, 40% probably were usable, but they're not the ones that are dealing with the recipient and the donor in the middle of the night and the risk and the stress associated with making that decision. So I think that's a little bit of Monday morning quarterbacking, if you will, and so I think the issue really is can we help people make a better decision? And we know, like and I think this is the huge opportunity of AI is we as clinicians have to make decisions on a short time with a limited amount of information. And what we learned on EVLP is there's a ton of information there that we weren't even seeing and we weren't considering. So I think all of those things together will make us better clinicians. Clinicians are still, it's very much an art, lung transplantation.
Yeah, absolutely. I mean, the cognitive load to consider everything you have to consider must be just massive. And that's where I think the potential for AI is.
Can I just add one thing too to that discussion? In our RCT, where we're in our live rollout, one of the things that we're seeing in the early results is when the model was trained, and then in the test sets and in the silent deployment phase, there's a consistent small proportion of cases where the lung was turned down, but the model actually said it would have been fine. And in our arm that actually where the model results are being released to the clinical team in real time, that number has almost gone to 0. So I think that's one piece where we're starting to see that effect. The other thing too is, as one of our tertiary endpoints of the study, is it's a simple Likert scale, but we want to know when the model was given, how impactful was it in the decision making? And so we can then track for cases that do better than others or decisions that were made. Basically, what was the influence of the model on that particular decision? And we can start to map those. So those will be questions we'll be able to answer more quantitatively as the study evolves. But I think we're set up to answer that question, as well as we're seeing early evidence that it's is working in the way that we would have initially hypothesized as a decision support tool.
And the other thing, Mohammed, I think this is really important for your entire audience, is when you're looking at AI in clinical trials and so on, when we first rolled out this trial, a lot of our patients said no. They didn't want to participate. And I thought, like, well, why? And the nuance was they thought your surgeon's going to make the difference, or the decision, or the computer is going to make a decision. And then we had to rephrase it to say, no, it's your surgeon making their decision the way they normally would, or your surgeon assisted by the computer. And then it's okay, well, that's fine. They just didn't want to hand over all of that decision making to a computer, and it was a misunderstanding, really. But I think it's a really important one. And I mean, there are some AI trials that truly the computer is going to make a decision. Can you discharge this patient or not? Or can you send the, you're going to keep them in the emerge or send them to the ward, like stuff you've been working on. And the question is, when does that bring risk into it, or when is it just helping to make a better decision? And I think it's important that patients understand that.
Yeah, absolutely. That's absolutely critical. And it's also kind of confused, I guess, because we have papers that have been published. So there was a randomized trial actually that was published, I believe, in JAMA Network Open recently, where they compared, they looked at diagnostic reasoning, and they what they did was they randomized physicians to kind of status quo of best evidence available. You kind of do what you do, and we'll give you the latest randomized trials or guidelines, or whatever have you, or you get a chat GPT type of solution to help you. So it's physician plus conventional versus physician plus generative AI. And what they're able to show is that they performed comparably, but the generative AI by itself outperformed both. So if you actually took physicians out of the equation, the diagnostic reasoning was actually better with just the AI alone. And I mean, personally, that's not what I've seen in practice, I think.
You know that, and
Yeah,
you know that, that's not what a patient expects, and not what you expect in clinical medicine. And so, I think we have to find that out. Like, when is the generative AI going to be wrong, and what are the implications of that? Whereas, the human reasoning on top of it maybe that can be taught and learned by a machine, but I think we're not there yet.
hmm,
The public confidence in that is not there yet.
absolutely, absolutely. All right, now I will get to the question in the Q&A box. Regulation. So how have regulators embraced these AI models, and how do you believe these AI models will be regulated?
Yeah, so I mean, it's a fantastic point. And so from an early stage, we were engaged with Health Canada to really start to make sure that we were aligned early on. And then ultimately, you're not building a bridge to nowhere. And so at the end of the day, what's really governing all of this is the guidance on software as a medical device. And there are very strict criteria where clinical decision support tools fit in. And ultimately here, where the insight model is being used is really on the decision support tool. Health Canada is very supportive of this. And so we're really in the final stages of getting that. So I think they recognize the potential, as Shaf mentioned, of using this tool not to replace, but to actually augment the decision making. And it does fit that narrative of a decision support tool in that guidance. So that's a really good point, and something I think really, again, the same thing is having that awareness early on in the project is really important, so that you do align yourself so you kind of know what that end game is. So when you come out of your trial, you're all kind of set for that last significant hurdle, but last hurdle.
And also, I think, the regulatory bodies like, lung transplantation itself, then ex vivo lung perfusion, are all things that they have a good side and they save lives and so on, but they're very complex, and different clinical teams perform at different levels. And so really what we've been trying to say is, can we really raise all boats? Can we show people how to do this better, more safely, with less mishaps? And one of the mishaps is sort of non-performance, right? Like, if you just don't take a lung, you never do a lung transplant, then you don't kill a patient, and you say, well, there's just not enough lungs to do transplants, and nobody can fault you for that to a point. And so really it's how do you improve the process? And I think, it's really important when you're translating these things to have the scientific backing that, look, even in a high performance lung transplant center like Toronto General, we showed that we increased the likelihood of the surgeon taking a good lung and not taking a bad lung by implementing these machine learning algorithms. And then we have to validate it in other centers, that it works just as well as the Mayo or at Duke or in Melbourne or something like that.
Yeah, no, very good. No, this is super fascinating stuff. There are now three more questions. I think we've got about 10 minutes left. We'll try and get through them. I'm
Mhm.
going to combine two of the questions. Um, One is from Meg Rathod. Great to see you again, Dr. Keshavjee and Dr. Sage. With the limited number of donor lungs and a lot of heterogeneity in lungs, where different donors vary significantly with respect to age, history of disease, quality, other factors, cause of death, how do you address this in building generalized machine learning models if the same parameters may have different implications depending on the donor's unique characteristics? And on a related note, there's going to be biases in recipient selection. So how are these biases addressed?
Yeah, so I think these are some of the issues, and part of the big problem is anybody can take a perfect lung, but there are very few perfect lungs, right? So there's underlying disease of the donor, there's underlying, smoking or other issues that all add to injury, that all add their different component of how a lung transplant turns bad, with primary graft dysfunction. And so what we're trying to do is develop scoring systems for this and put it in, and it really becomes an unwieldy amount of data. And then the other side of the coin is the recipient, and you can put a perfectly good lung in a recipient that, and the whole thing can turn to mud. And it's not that the lung wasn't good, it's the recipient was high risk or had high inflammation and so on. So ultimately, again, this is a wonderful opportunity to apply big data. Like, we have complete data on analysis of big data. We have complete data on our donors, we have complete data on our recipients, but we tend to look at them separately. So we really now have a database that looks at the whole lung, the whole trajectory of the lung, from the donor to the transplant operation to the transfusion history to the underlying disease of the lung to the genes in the lung to the reperfusion injury to the genes in the recipient, and the degree of illness. How much pulmonary hypertension do they have? How old are they? How frail are they? All of these things now can start to be put together so that we can look at the big picture and say, this lung in this recipient, you can expect this 10 years down the road. We don't know that yet. We know if they get through the transplant, we can say what to expect 10 years down the road. But really, how does that reflect the lung that went in? Right? We haven't put that data together. So those are the things that we really are need to work on.
And one other thing on the donor side, one of the things that's emerging is it's truly the functional data that's driving the model predictions of outcome. And so that's really the value of that analyses here, because what we're seeing in a good example of that is typically two donors, or donors come from two different streams, either brain death or cardiac death. And those lungs might start very differently at the beginning of ex vivo, but by the end, they're very similar in the sense that that classification, or that category, is not an important feature at all in the model. It's the function of either lung in and of itself. So a lot of these sort of clinical histories are explained or manifest in the clinical or in the functional data. And that's really, I think, what allows the model to generalize across donors, because ultimately it's the function at the time of transplant, not the label that it was a brain death or a cardiac death.
Yeah, absolutely. And so, and that's the beauty of machine learning, right? It actually takes that variability that you see within the data repository that you have, which is fairly unique worldwide, with an incredible amount of multimodal data to actually figure out what that variance is like and actually try and tailor things to an individual patient or donor and recipient. On the bias side, though, are there kind of general surgeon biases where you kind of say, oh, you know what, this person's a little bit too old and maybe that wasn't the right decision? And are there those biases? And then how do you, if there are, how do you correct for them?
I think, one of the things is it's like anything else in surgery. Like, there's some operations that shouldn't be done in certain places, and we tend to do the high risk ones and so on. And then again, you could have a negative impact of the fact that, and that's why we risk adjust our outcomes. But the point of it is, I think that we need to be looking at that in more detail so that those biases aren't there. I mean, certain patients, it really could increase access to lung transplantation, right? Because not only will you pick patients and risk adjust them properly. You pick donors and use more donors and risk adjust them properly, so that you really don't compound risks with the donor and the recipient that you take. And you really won't be able to just, this is starting to happen where you really just can't turn down a patient and turn down lungs and turn down lungs and turn down lungs, because now actually there are things that they look at in the organ procurement organizations where they say, well, you turned down this lung, but it got transplanted by the other center and with a very good outcome. So why did you turn it down? And your patient has been waiting longer. So it really does sort of force performance elevation little by little. So, I think in time to come, some of those biases, it'll level the playing field a bit, and
Absolutely, absolutely. And I think there are mechanisms to actually, for depending on which model you use, to actually correct for the biases mathematically, but also just actually to do a really kind of thoughtful review around,
yeah.
well, maybe there was a bias in this case, and so then feed the data accordingly.
They've shown also that centers that do less than 10 transplants a year tend to do low risk people and turn more people down, and tend to take low risk lungs and only perfect lungs and turn a lot of lungs down. So that's part of the problem.
That's fair. We've got time for one more question. So now, instead of the patient donor side, we're going to go to the clinicians. Do you see any challenges with clinicians at other centers accepting the results of the model? Do you think there's going to be pushback to say, oh, this is too high tech?
No, again, we're lucky that we work in a position of leadership. So people look and say, well, what are they doing in Toronto, and how are they getting all these lungs transplanted with such good results? So hopefully we can lead from that position of clinical leadership. But by the same token, I think we hold ourselves and they hold us to the same bar, that, okay, it's fine, it works in Toronto General, but does it work everywhere around the world? So I think we need to do that. But the part that I think the clinicians are really embracing is the fact that it's bringing precision into a very difficult area. And really, at the human level, it decreases stress. Like right now, when I get a lung that I take off EVLP with all this information, I'm not so stressed about whether it's going to work or not. I know it's a good lung, and I've never had that luxury ever before. So I think that is worth so much to the clinician in this type of an area, that I think we get less pushback. But certainly there's the issue of is it right? Is it biased? Is it, oh yeah, you can do that in Toronto, we can't do that? And the other issue is, yeah, how will we do it? So what we're doing now is building these AI algorithms into our machine. So not only will it do the EVLP, it'll tell you the answer. It's a good lung, right? And I realized that even as experienced as we are, when we started looking at the data, there were very, very small trends that we as clinicians missed. But the computer said, like, if your pulmonary artery pressure goes up from 9 to 11 on EVLP, that's a significantly high risk of death of the recipient. But 9 to 11, we kind of ignored. We didn't know that. When we looked at 1,000 cases, we saw that 9 to 11 is a significant trend, and it's one of those parameters to be taken into consideration.
Yeah, it's fascinating. We are almost at time, and I really, really want to thank both of you, Dr. Keshavjee, Dr. Sage, for enlightening us. You're phenomenal speakers, incredible work that you're doing, and ultimately, the patients you're going to benefit is going to be transformative. So thank you for your incredible time and sharing your knowledge with us.
Great. Well, thank you for what all of you are doing too in the field. We're learning a lot as we go along.
No, thank you. I think we're all learning from each other, but at the end of the day, it's patients who are going to benefit. So that's why we're all here. Thank you. I'd like everyone to complete the feedback survey if you can just spend a few minutes doing that. Thanks to everyone for attending the fascinating talk. It was spectacular. Once again, this event is CPD accredited for physicians. To obtain your CPD credit, please scan the QR code on this slide and complete the form. If you aren't already a T-CAIREM member, you can join us by visiting our website for eligibility requirements. And don't forget to follow T-CAIREM on LinkedIn We are now one of the biggest AI medicine networks in the world, and we want you to be part of it. So thank you, everyone, and have a good afternoon.